And now let's turn to today's clinical topic. Our speaker today is Dr. Tim Kosinski. And of course, you all know Dr. Kosinski. He is a very sought after speaker and teacher in the world of implant dentistry. He's taught literally hundreds of courses. He's written dozens and dozens of articles, and he's been a mentor to many dentists as they successfully add implant dentistry to their practices. So Tim had a great idea for this lecture today. Unless it's really great, then it's going to become my idea. But what he said is, I get so many questions after my courses. Let me go through some of the most commonly asked questions, and let's just make a whole lecture that's based on the answers to these very commonly occurring questions. I think it's a great idea, and of course, Tim has such a great way to make this information straightforward and relevant. So I'm going to turn it over to Tim, and I am looking forward to today's lecture. It's all yours, Tim.
All right. Hopefully we can see that
Looks great.
perfectly.
Perfect.
Hopefully we're good. And well, welcome everybody. It's always an honor to do these programs. And as Dr. Park mentioned, we do a lot of the two-day implant training programs for Glidewell, and I'm very proud to be associated with that. And I think I'm a really good teacher. I don't know if I've ever said that before. But every time I give a course, I will get 2, 3, 5, 10 emails in the following weeks after the course asking really good questions. And I'm always a little alarmed because I thought, gosh, I really covered that really well in the program. What did I miss? And so that always helps me become a better speaker, a better instructor. Because my goal, I like to say this, and Dr. Parks heard me say this many times, I was blessed with great mentors throughout my career, and it's really an honor to be able to give back at this juncture. So I came up with the plan of just answering some of the common questions and then relating some of the clinical applications. And hopefully, for those of you who are listening, if you do have the same cloudiness in what we're trying to evolve into, you'll become better. So enough said. Our objectives, real quick here. I want to get into the questions. These strategies will help you become more clinically successful. Everything that we talked about at this juncture with the business panel is relevant. Growth, becoming a super GP, incorporating the most financially rewarding procedure that you can do in your practice, and that is implant dentistry. More than just prosthetic reconstruction, but the surgical applications. And I'm a true believer that general dentists are often the best source of providing this service to our patients because we understand teeth first. It's more than placing this little spark plug in the jaw. Immediate implant placement, we have some questions on that. Grafting, we had some questions on that. A little bit of materials. We won't cover too much on that. And one of the questions, the first question that we had was on sinus tenting. Now, I'd like to begin all my programs by saying, I ask, how many people are doing implants? How many do 100 a year, 50, 20, 10, 5? How many aren't doing any implants? And why? Why aren't we doing more implants in our practices? And the answer is almost always, well, education, the investment in getting involved in the procedure, and the team at Glidewell has made that much more financially possible for us as clinicians. But we're concerned about anatomy. We know that when we lose teeth, bone shrinks down and in the lower jaw, up and in the upper jaw. And how do we handle? We don't want to harm a patient. How do we handle the mandibular nerve area? How do we handle the sinus area? And so planning and guided surgery has certainly helped us, but we still have questions on how do we achieve these results. So let's look at the first question that we had regarding the placement of a Hahn 5.8, a 5 by 8 millimeter dental implant in the number 3 site with a sinus lift. Doctor said my sinus osteotomes width begin at 2.6. The twist drills that they're using are 1.5, 2.4, and 2.8. And after which twist drill do I use my 2.6 sinus osteotome to begin my sinus series of 2.6, 3.1, 3.8, 4.5 prior to placing a 5.8 Hahn implant? And that was from Stephen F. out there. And very specific question. that I'd like to answer. So we have a situation, we take a periapical. We don't really know where the floor of the sinus is, but we do have that dark line that we kind of disseminate. We say, well, maybe that's the floor of the sinus. It may or may not be, but we don't have a lot of room. 5 millimeters. Doctor wants to put an 8 millimeter implant in there. So we can two-dimensionally actually determine how much space we really have. And when we use the Hahn implant system, which I think is the finest implant system in the world, I think Dr. Hahn was brilliant. I think he took the best of the best ideas that were out there over his myriad years of experience and created something that we as general practitioners can become very proficient and efficient at. And here we took a pilot burr, a first burr, and it's 4 millimeters in depth. We place it, and when we teach, we're not going to teach the implant protocol, but I'm looking at mesial distal direction. We're thinking tooth first. We're trying to design a tooth. We like to say that the width of implant we like to use will be half the size of the tooth we're trying to replace. So if we're trying to replace a molar tooth, 10 millimeter, 9 millimeter, I'd like to use a 5 millimeter implant, assuming that we have facial, palatal dimensions. We have soft tissue to determine. I'm going to go through this kind of quickly, but 8 millimeters to soft tissue. This is going to mean we're going to want to lift the sinus. Now, this is where we get specific. Doctor asked a question, but he was using different systems. He wasn't using osteotomes, and osteotomes are simply instruments that rather than cutting hard tissue, condenses the hard tissue. I like to say we take styrofoam and we condense it to make IKEA furniture. So Dr. Hahn and Glidewell created a specific osteotome set that matches the Hahn implants directly. 3.0, 3.5, 4.3, 5.0. So it's a very specific osteotome kit. Doctor in the question was using generic ones that are close, but they're not exactly precise. So his question kind of overlaps and it's a little confusing. Maxillary bone is very porous, and I will often undersize my osteotomy with these osteotomes to get more torque during seating. The osteotomes actually compress the available bone rather than cutting and removing it. So if we're going to use this system, and in my course, I say, if you're going to jump in with both feet, make the investment. I know the reps that we work with in our courses are just excellent. Mr. Glidewell wants you to be successful. So to do that, you have to have the right tools. So I strongly recommend that doctor invest in a osteotome system that mirrors the implant that he's going to place. So here we're taking the osteotome, and I can make digital measurements. Every digital X-ray unit, we use DEXIS, has a measuring tool on it. So I can know precisely the amount of bone that I'm using. Well, doctor then came back saying that he wasn't understanding. So I should use what you have, but undersize one complete diameter. Can you explain? And again, maxillary bone is very porous. It's the worst bone in the body. And I undersize the osteotomy with the osteotomes to get more torque during seating. So what that means, if doctor wants to put a 5.0 by 8 and we lifted the sinus floor, we demonstrate this in our courses, we can lift the Schneiderian membrane of the sinus floor 3 millimeters predictably. But my rule is there must be at least 70% of viable natural bone to maintain that site. We can lift the Schneiderian membrane up to 6 millimeters easily, but I would not immediately place an implant. So if doctor is intent on using generic osteotomes, which many of us use, he has to do a little bit of math, and I would always undersize. Now remember, the Hahn implant system is a 0.5 millimeter wider than the osteotomy we're created. And Dr. Hahn created an implant system that has very sharp threads, for self-tapping. And so undersizing in soft bone is very, very predictable and possible in your practices. Mandibular bone, totally different. A cortical bone, totally different. But in the posterior maxilla, I want you to learn to feel comfortable condensing the bone, not cutting it away, and elevating that floor of the sinus. So really, really great question. So to carry through with the clinical, we're using an osteotome and we're using a mallet to tap, lifting that Schneiderian membrane up. We can make measurements. Now, if you feel that you may have perforated the sinus, you're going to perforate with a very small diameter burr, not a large one. But if you feel uncomfortable or unsure, I will take a resorbable membrane. This is from Newport Biologics. It's resorbable, cut a little manhole cover, and it becomes my parachute. Take a little Newport Biologics allograft material, place it into the socket, and I can thread the implant directly to position, getting initial stability, lifting that sinus floor up to 3 millimeters. You can see that we can do this predictably, easily. But my advice is if we're going to do this, be consistent with the instruments. These are not expensive instruments to purchase. And if you're going to do these type of procedures that you're a little afraid of, as we said in the very beginning, have the right tools behind you. And the team at Glidewell is able to not only fabricate a very functional crown, but something that I feel is going to have great predictability and longevity. Question 2. All right. Since your course, I placed about 20 implants, and I'm so honored when I hear that. I'd like to say in my program that the doctors that take the program, you have about a 2-week window to place your first implant. If you don't, you're probably not going to do it. And you don't place it for a number of reasons. You didn't make the investment initially. You don't feel comfortable. There's patients out there. That's not an excuse. If you don't place your first implant within a 2-week window, you're probably not going to, and then you're going to take another course and another course and another course. Doctor says that they really enjoyed the system and learning more about more at every placement. Like to try an anterior with a surgical guide. We have 3TX Studio for imaging software and a Cavo Op 3D CBCT unit. CTX does not have the Hahn tapered implant as an option. Looking for suggestions of new software. I am curious what you use. Second of all, what software do I use to receive a surgical guide from a lab? I want to eventually print my own, but I'd like to try some lab-made ones first. I am just exporting a CBCT file and iTero scan, and that's from Brandon. Great question. Scanning, amazing. Milling, amazing. We incorporated all of that technology, all the AI in my practice. We are able to virtually not only place our implants with CBCT analysis, but we're also able to virtually design the final prosthetics, the final prosthesis, understanding function and aesthetics prior to any surgical intervention. What a great time to be a dentist. But how do we do this? Surgical guides are very specific. And I like to say this, and I've been doing this a long time, 38 years. I place over 18,000 implants. I do guided surgery, but guided surgery is not a panacea. It is a tool that, again, makes us proficient and efficient. But the guide is only as good as who fabricated it. So predictability, precise impressions, scanning, incorporating the CBCT is important, and you want to work with a quality diagnostic laboratory that is going to make you fine-fitting surgical guides. The team at Glidewell works with the Hahn implant system. They will work with you to incorporate this to become a practical part of your practice. So my suggestion to Brandon was contact the team at Glidewell, the imaging area and the guide department, and work with them. Know what their specific protocol is. Doctors, there's no shortcuts. This is not an easy process. This is very complicated dentistry that you have to understand. We can do reduction guides. We can fabricate surgical placement guides. And with the Hahn implant system, you have to purchase the Han guided kit. I've worked with probably 8 or 9 surgical guide kits over the years. And what was created with Glidewell and Dr. Han is by far the simplest guided system to use. Personally, I don't do my own diagnosing and planning. I don't have time for that. We're doing 80, maybe up to 100 implants a month. That's not my forte. Maybe it's generational, but it's not my forte. So I rely on the team at Glidewell to sit down. My daughter, Jessica, will set up an appointment. Usually it's my lunch hour from 1 to 2. They will precisely call at 1 o'clock after I've sent them models or scanned models, sent them to CBCT. These are quality people that can manipulate the software very quickly. Now, it's always in your hands. You have to make the final determination of what you accept. You tell them the size of implant, the position, what you're trying to achieve restorative-wise. Are we able to do this case predictably? When I was young, I was trained, visualize the case finish before you ever start. That's an art. That's an art that probably took me 10 years to master. In today's technology, we are all equals. We have the digital acuity, we have the ability to diagnose and treatment plan, virtually design, place, and restore our cases prior to any surgical intervention. And it also allows us the opportunity to communicate. So what I'd like to do is set aside a half an hour at my lunchtime. They have all the information. We go through it. Dr. Kosinski, we understand you want to put 6 implants in the maxilla for a full arch implant retained Bruxer prosthesis. We want to know where access holes are going to be. Is this going to be cement on? We have to understand the amount of interocclusal space. That's very imperative with these cases. We have to have 14 to 16 millimeters per arch of interocclusal space to do these fixed implant retained prostheses. Very, very, very important. And our attorneys will tell you that you need to know this ahead of time because you can place the implants and not be able to restore them later. So I don't sit down and do my own. I didn't purchase the software. That's not my forte. I'm letting the team do this. Now, I know Glidewell has specials and they will fabricate at a reduced fee. I don't mark my guides up to my patients either because it just makes me more proficient and efficient. The time is spent preoperatively and makes my surgical applications that quicker. So to answer Brandon's question, I allow on the experts to efficiently help me plan. It's always in my lap. I make the final determination of what I can and can't do. And so it's important that we realize that. But we're able to virtually design, place our implants prior to any surgical intervention. Another question. When can a tooth be removed and an implant immediately placed versus removal and grafting first and waiting to place the implant? Great question. Do I need to graft the socket when placing an immediate implant? Another great question. And what graft material can I use? These are very, very important. Now, my rule of thumb and what we teach in the lectures is a tooth needs to come out. If we can atraumatically or minimally traumatically remove that tooth, and there's not active infection around that tooth, I love immediate placement of implants. We will create an osteotomy. We have to get initial stability, so we have to go beyond the apex of that socket. The implant is not necessarily placed into that socket because the facial plate may be very, very thin. Oftentimes, we lose a facial plate of bone. And in my lectures, we will demonstrate how to grow bone. And I like to say, I can teach you how to grow bone 100% of the time. That's a very bold statement from a guy from Detroit, but we get very, very good predictably with very specific materials. We don't have a myriad of materials. So let's go back to the question. Yes, I love doing immediate placement. No question. It saves a lot of time and energy, but oftentimes I can't. Now, where would I not place immediate implant? Well, mandibular posterior teeth, molars, 3-rooted teeth. Where do I want to place that implant? You're thinking tooth first. I want to idealize every implant position. In a maxillary molar, the palatal root would be the ideal. I don't want to put the implant in the palatal root because my aesthetics and the feeling, the tooth is going to be too thick on the palate for the patient. I don't want to put it in the mesial facial root or the distal facial root. I want to put it right in the center. The maxillary molar tooth is not an aesthetic area. It's a functional area. So by far, the vast majority of time, I will remove a non-restorable maxillary molar tooth and graft each of the sockets. I will wait 3-4 months. Integration will occur from the apex towards the crest, and there's certain rules that have to be followed. Then I can eventually place an implant, ideally thinking tooth first, facial lingual, facial palatal, mesial distal. The other time that I don't immediately place an implant in a socket site, if there's active infection in that site. I don't have a problem removing the granulation and grafting that site. And I use the analogy of if you've ever had a hangnail. We were talking about Disney before the meeting started. You know, you're just miserable. Having a hangnail is terrible. It's very painful. You go back to the hotel, you go home, you soak your foot, you cut it. 5 minutes later, you forgot that you even had a problem. The body is an amazing thing. Once the source of the infection is eliminated, the body will heal rapidly. So I will graft that site predictably, but come back and place the implant later. And I think the public patients really understand that. If it's a tooth that doesn't have active infection, I love immediate placement of implant. But when we remove a tooth, we create a socket or hole. That socket or hole is shaped like an egg. Our implant is round. So we fill that void with a grafting material. We'll briefly talk about the 2 different types that I use. And it's almost like caulking. And I think our patients really understand what caulking is. And it fills it in. Now, the literature will say if the gap between the facial plate of bone and the implant surface is 1 millimeter or less, you don't have to graft. But I pretty much routinely will graft a socket and then thread my implant directly into that socket. Now, with our implants, we want to place that implant about 1 millimeter subcrestal into that socket because physiologically, we expect about 1 millimeter of bone loss in that area. So just be aware of that. Which graft materials do I use? And how do I decorticate the bone with a round burr implant drill? Great questions. I'm embarrassed that they're asking it because I thought we covered it, but maybe not well enough. So let's do it again. I use 2 different graft materials in my practice, just 2. 100 ways of doing what I do, but if you want to grow, if you want to be mean, you want to grow bone the way I do, this is what we do. I use the Newport Biologics allograft material, 250 to 1,000 microns, cortical cancellous. If we're using an allograft material, we must protect that allograft from invagination of epithelium. Epithelium grows 10 times faster than bone. Bone will integrate from the apex towards the crest. Epithelium will go from the crest towards the apex. Epithelium will always win. So if we're using an allograft, we must protect that allograft from invagination of epithelium with a membrane. I use the Newport Biologic collagen membrane, 3 to 4 months. That's the only membrane I have in my practice. That membrane must be specifically positioned and it must remain intact for at least 6 weeks. And we have to show you how to do that. There's techniques that are done to show you how to do that. I know as general dentists specifically, we understand that. We understand membranes. We have a tendency to tuck. We push and tuck and we try to force something and we give up and we suture over the top and that membrane comes out. If that membrane dislodges before 6 weeks, the integration becomes unpredictable. I don't know if it's going to heal or not. And we've probably all had that situation where we've done a graft, we thought we did a good job, we come back and it's mush. That's unacceptable. If we're going to do these procedures, we want predictability. The second graft material I use is a material from Implant that Glidewell, the team at Glidewell has in their inventory. It's called Osteogen. It's calcium apatite in a bovine Achilles tendon matrix. It's a very specific graft material that is sintered and it converts to bone. It's calcium phosphate similar to natural bone, and it's something I use literally every day in my practice to grow bone. I can objectively look at it radiographically. Remember, bone is going to change over from the apex towards the crest. Our initial stability with any implant is in the apical 2 millimeters. So we get our initial stability, and it saves a lot of time. If you have a socket, the socket must bleed. Purple blood is bad. Granulation is bad. So you have to use a sharp curette. And again, the team at Glidewell can provide you my grafting kit that we use in our practice, sharp instruments, remove that granulation to the best of your ability. If you don't have bleeding, you will not get integration. If you have to decorticate, I will use a round burr. You want bleeding sites in that area. So great question from Michael. So at the time of extraction, these two slides, when we finish, you might want to take a snapshot because this is how you educate your patients. Time of extraction, we help minimize or prevent bone loss. We support the soft tissue architecture, critical to aesthetic dentistry. Helps minimize periodontal pathology and will provide adequate site for implants in a short 3 to 4 months. And you can objectively determine that radiographically. If we don't graft, patients say, no, I don't want to pay for that. We get soft tissue infiltration. We said that epithelium grows very fast. We get loss of ridge height and width, which makes positioning of an implant in the future may be more difficult. The literature will say without grafting in an extraction site, we will get 30 to 60% bone loss in a 3-year period, which means that the patient may need a more invasive surgical procedure to grow bone, a bone block, autogenous bone from a site. It becomes expensive and time-consuming for the patient. The resorbable membrane I use is from Newport Biologics. It resorbs in 3 to 4 months. I only need it to work for 6 weeks. It's purified intact collagen from porcine peritoneum. It's very easy to manipulate and allows me to place it. And we have to passively position it. So in my courses, in my YouTube videos, we show you how to make an envelope reflection. We're not making vertical incisions into the tissue. Most of us are trained to do that. I do not incise into mucosa. If you incise into mucosa, you lose control of the reflection, and you also get prostaglandin and histamine release, and the patients will be uncomfortable. Patients don't need to have a lot of pain. We will do these full arch cases, and the patients will be given 600 milligrams of ibuprofen, as long as you're not incising into mucosa. So we have to passively place that membrane at least 2 millimeters beyond any defect. If I don't have a facial wall, as long as that membrane is passively placed at least 2 millimeters beyond the defect and it remains intact for at least 6 weeks, you will grow bone 100% of the time. Epithelium grows 0.5 millimeter to 1 millimeter a day. I do not need primary closure with this procedure. I need that membrane to be placed at least 2 millimeters beyond the defect. I don't need primary closure, and it must remain intact for at least 6 weeks. The Newport Biologic mineralized allograft is cortical cancellous. It's osteoconductive, and I will wet it with sterile water or sterile saline to make a gel. So it makes it very easy for me to load. There are syringed materials, but this is what I do every day in my practice. It's very cost effective and allows you to provide this service at a reasonable fee for your patients. Remember, concentric circle, the most financially rewarding procedure you can do in dentistry today is implant dentistry. Implant, abutment, crown. Extractions, grafting are important to set the foundation to build the house. The Osteogen plug, as I mentioned, is calcium apatite. It's very simple to use. I will use this when I have all the walls intact. I can thread my implant directly into this material. And again, I do not need a membrane with this material, which makes it even more cost effective and simple to use. In our bigger cases, we will draw blood and I will do platelet-rich fibrin. Let's not go too much over this because we need to finish up the program, but it will give us the same result with a graft, allograft, and a membrane, or the Osteogen plug without a membrane. It's just faster healing. The results are the same. We have to draw blood, and it takes a little bit of time to spin it, but we get platelet alpha factors and platelet-rich bone morphogenic proteins in our membrane. So very quickly, I'm going to finish up, Neil, with this case quickly, and then if we have questions, and we got through 3 questions, we're going to have to do this again, Neil. I'm sorry, but it's important. We have a tooth that's deemed non-restorable, periodontal defect, a post that had a horizontal fracture. I see doing more implants on root canal treated teeth that have posts than any time in my career. I think the world is stressed out. In the age of COVID, it's important. We take a radiograph, make sure that there's no root tips. And you can see here, I do not have a facial wall. We all agree we do not have a facial wall. So I'm going to make that envelope reflection, no vertical incisions in the mucosa. I have complete control. I place my implant. You can see there's absolutely no facial threads, but I did get initial stability. That implant is placed 1 millimeter subcrestal. We have our resorbable Newport biologic membrane, cutting it to site, passively placing it at least 2 millimeters beyond the defect. Doctors, you have to feel comfortable reflecting tissue. You just have to learn this technique, and that's what we teach you in our courses. We place it. This becomes my new wall. I then take my wetted allograft material, wetted in sterile saline, sterile water, never with anesthetic. Anesthetic is pH of 2, and it will inhibit bone growth. I passively place my membrane onto the palatal surface, and my implant is in position. Take a radiograph, 1 millimeter subcrestal. You can see the big defects, big radiolucencies around that area, and eventually we can fabricate a final crown. Neil, I'm going to stop here. I'm a little bit over on time, and we'll do question 4 through 32 in future meetings, if that's okay with you. And if we do have
4 through
questions,
32.
we'll
Okay, well, we will reserve a few weeks for you next next year to cover
Okay.
some of these. That was great. I mean, you know that these are the issues that are concerning doctors because they're the questions that you get. So it was a great way to respond. You did a great job. We got a few questions coming in while you were answering questions. So let's go ahead and take those. And got a lot of questions about grafting materials. So here's a question about, hey, when you do immediate implants, do you mix the allograft with BioOs? BioOs is, of course, a xenograft. Do you ever use xenografts? Do you ever mix allograft and xenografts?
I'm just a practical guy from Detroit and just been doing it a long time. And Neil, we've gone back a long time, and you remember I started with plaster of Paris, glass beads, hydroxyapatite, tricalcium phosphate. None of it worked. It was marketed, it was hyped up, but it wasn't predictable. And we need predictability. There's 100 ways to do what I do. There's so many different materials. Why do you want all that stuff? I'm telling you, if you want to be me, I use Newport Biologics allograft, 250 to 1,000 microns, and I use Osteogen calcium apatite in a bovine Achilles tendon matrix, and I use the Newport Biologics membrane, to 3 to 4 month membrane. I don't need primary closure. I'm always evaluating attached gingiva. That's what I use. That's what I invest in. I never use BioOs. I haven't used BioOs in 30 years because it doesn't bleed. It's a good material it's cement, but it's not, in my humble opinion, a good material to place an implant in to get integration of that implant.
It's a great material for making the X-ray look better, though. Right?
Okay. Yes.
That's yeah. So I'm with you. Not a big fan of xenografts. Don't really see
I don't use it.
Yeah, the need for it. So you're very clear that a lot of times you'll use the osteogen plug. So this is when you're doing an extraction. You're going to come back later and place the implant. Sometimes you use the osteogen plug, and then sometimes you use allograft with a collagen membrane. When would you cross over and go, oh, well, this is a little bit too much for osteogen. I need to use the allograft and the collagen membrane.
Yeah, and that's really important. And the whole crux is predictability. If you're going to do this procedure for your patients and you're going to charge the patients some amount of money with the idea that you're setting a foundation for your financial rewarding implant abutment and crown, you want to set a foundation. My rule of thumb, and let's keep it real simple. If you have all the walls intact, I call that a four-wall defect. Facial plates there, I would place the osteogen material. It's $40, okay? And it's simple to place, and I can thread the implant directly into it if I do immediate or if I want to graft. I will get integration. Remember how it heals from the apex towards the crest. In 3 to 4 months, depending on the size of the socket, I can take a radiograph and I will see a change. Done a lot of histology, a lot of research on this. It is a great material for $40. So what do you charge the patient? Okay. Don't make it prohibitive to do this procedure. Dental insurance is going to cover it anyways. But it's important, those two slides, those back-to-back slides, you have to educate your patients why it's important. If the facial wall is gone, I will use a resorbable membrane and allograft. If the defect on the facial, my rule is 5 millimeters or more, I will make my envelope reflection, use a membrane and allograft. That gives me predictability. You know, we're pretty set in our ways as general dentists. We like our composites a certain way. We like our curing lights a certain way. We like our impression materials a certain way. That's what I do, and I get predictability. So when I take a tooth out and I graft, I know, not even a question, I don't lose any sleep. I know that I'm going to have bone in a certain amount of time.
Got it. There's so many people out there that try to make this more complicated, and we really appreciate the fact that you're working hard to make it simple.
Yeah.
Look at the kind of case it is, look at the number of walls in the socket, what's missing, and then choose from a couple of choices based on that. I think that's a really good way to teach, and it's a really good way for people to practice. So I really appreciate that. I want to do one more question, and it's related to the full mouth, after full mouth extraction. And the question the doctor wrote in, during grafting for full mouth after extraction, what should we use as a temp for patient to eat? Now, first of all, a lot of times when we do full mouth extraction for implant placement, we don't necessarily do a lot of grafting, right? We've got enough sites. So can you comment on that, on the first part of it, of are we doing grafting in a full mouth extraction?
That's really important, especially in today's environment with the all-on concept, all-on 4, all-on 6, immediate load. Personally, I've been doing this a long time, right? Almost 40 years experience in placing implants. I can tell you what's going to happen to our implants 10, 20, 30, 40 years from now. And they ain't necessarily going to be there, And so I'm very, very particular. And I think I think we did 52 full arch cases in the office this year. That's a lot. And I don't immediately load a lot of them. Remember, there's certain rules that have to be followed. You need 14 to 16 millimeters of interocclusal space per arch. These are rules that you better know ahead of time and work with the team at Glidewell in determining your presentation prior to any surgical intervention. But let's assume we're taking teeth out and we're going to stage it. I would take the teeth out, get rid of the diseased bone, understand that if we're doing overdentures, we need 8 to 12 millimeters of interocclusal space. So sometimes we have to remove bone. If we're doing implants and bridge work, I would place the implants directly into the sockets and do custom abutments and do cement-on prostheses. It's not popular today, but we don't have to remove viable bone in the future. So it all depends on what we're trying to achieve. When we lose teeth, we take teeth out, bone is going to shrink up and in. In the posterior maxilla, those tooth roots act like a tent pole holding up a circus tent. You take away that tooth root, that circus tent's going to collapse, and then we have problems down the road. So I like grafting. If we can draw blood and get PRF in those situations, we don't need a lot of grafting material. But bone is gold to me. It's very, very valuable for setting the foundation for a house that's going to be around for a long, long time.
Got it. That's great advice. Great advice. Here's an interesting question about what's the time frame for doing socket grafting? So let's say the extraction was done in another office, and now the case comes to you. The socket's not fully healed, but can I still do a socket graft, or do I let it fully heal now and then just do a regular augmentation?
That's a great question. Very pertinent. A lot of our oral surgeon colleagues, they take teeth out and then they come back down the road 2 or 3 weeks down the road and graft at that time. It's going to take time for integration to occur. And remember, it occurs from the apex towards the crest. So you can go in there and curette that area out, graft the site with the material of your choice, and allow it to heal. I think that's smart. If you take a tooth out, I don't know where it's going to heal. Is it going to shrink? Is it going to form a horse's saddle? Is it in the aesthetic zone? There's a lot of things that come into play, but our oral surgeons oftentimes will extract and go back and grafting, and they do that for financial reasons because they get insurance to cover it. We're not getting grafting covered by insurance very often. So make it cost effective for the patient and make them understand why this is important. If we don't do this now, they may not be able to have an implant down the road without a much more invasive, expensive surgical procedure.
Got it. Very good. Well, Dr. Tim Kosinski, as always, thank you for a great lecture. This was a real fun one. I really like the idea of answering all these questions, and maybe we'll do this again. And thanks to our panel for their great advice throughout the year. And thanks, everyone, for joining us today. We're going to be off for the next 2 weeks for Christmas and for New Year's. And we want all of you to have a great holiday season. And we'll be back on January 5th. So be sure to join us when we'll have Dr. Eric Block, and he's going to be presenting on stress-free dentistry. We can all learn how to practice like Dr. David Hochberg, stress-free dentistry. All right, everybody. Have a wonderful holiday season. Great New Year.
Happy
and we'll
holidays,
see you next
everybody.
year. Thanks,
Happy
everybody.
holidays.